Hello and welcome everybody to this, our most recent equine webinar, equine medicine webinar to be specific. Welcome to you from wherever and whenever you are listening in the world. We hope you enjoy the hour or so we have here this evening to discuss equine ophthalmology in a broad sense. Just before we get on to introduction of the speaker, who, to be honest with you, probably requires very little introduction, but just a couple of housekeeping points to make. We are going to be taking questions at the end, or I should say Derek's going to be taking questions at the end, but I would please ask that we keep those questions for the end, and in the meantime you just watch, listen, learn, and then we will address those questions once the presentation is completed. So if you look at the control panel for your GoToWebinar window, you should see there is a little title bar or menu entitled questions, and if you go in there you are able then to submit a question, and I will keep an eye on those throughout the course of the presentation. I will collate those questions. I'll probably give you a couple of gentle reminders as we go through, just to make sure that people put questions down when they have them, and then at the end I can pose those directly to Derek, and he can do his best to sort of get answer out to everybody. Whilst the presentation is going on, if separate from that you have technical issues, please put those into the chat section, not the questions section, but the chat section, and I will keep an eye on those and do my very best to address any technical sort of queries or issues that might arise. Fingers crossed we won't get any. So this webinar forms part of an ongoing series of webinars that we here at IMV are running, both equine and small animal, in order to promote and support the use of imaging in veterinary practice. It's something we believe very passionately in at IMV Imaging, is that we're not just supplying imaging equipment, but we're trying to do our very best to make sure that actually as end users you can then gain the most from it. And as part of that, we try to support CPD wherever we possibly can. As I alluded to right at the beginning, I don't think our speaker really needs much of an introduction. I would be surprised indeed if any of you listening this evening have not come across him. However, Professor Derek Knottenbelt is a specialist in equine internal medicine and a diplomat of the European College of Equine Internal Medicine. Derek retired from a personal chair in equine medicine at the University of Liverpool in 2010, so over a decade ago now, having run a sarcoid referral service there for over 20 years. He has received the Animal Health Trust Scientific Award in 2003, the Beaver Blue Cross Welfare Award in 2004, and then the Merck Weaver Welfare Award in 2006. In 2005, he became Professor Knottenbelt OBE, courtesy of Her Majesty the Queen, for his services to equine medicine. And in 2018, he was awarded the RCVS Inspiration Award. Then in 2019, he was awarded an honorary membership of the ACVIM in recognition of his lifetime's contribution to improving the health and welfare of horses worldwide. And as if that wasn't enough, Derek is actively involved in animal and human charity work, both in the UK and abroad. He's also a founding member of the Vets with Horsepower team, raising money for charity through the provision of high quality CPD to vets and horse owners. And probably at this point, it would be fair to also have a little plug of the upcoming monster Vets with Horsepower CPD event. I think it's fair to say, I hope I'm not spoiling anything here, Derek, by saying it's due to be a world record continuous education broadcast, over 25 continuous hours of education. It's a legitimately startling, humbling, and frankly wonderful event. I may not feel that on the other side of it when we're 25 hours in, but at this point, I'm proud to say we will, in our small part, be involved in helping support that. It's an amazing job you guys do, and all the Vets with Horsepower team. So without any further ado, I think it would be fair to hand over to Derek, and I hope you all enjoy what will undoubtedly be another fantastic presentation from the man himself. Derek, over to you.
Good. Thank you so much for that very kind introduction, and welcome to everybody. I hope you're going to enjoy this. It's a bit of light-hearted fun, just like the horsepower event on the 29th. This is a bit of fun, and I thought we would tackle ophthalmology from an obtuse angle, if you will. Imaging is the most important thing, as we all heard a minute ago, and IMG are amazing for this. They do help enormously, and they have a very strong reputation in imaging. But of course, there's nothing more imaging than imaging and photographing and looking at the eye of the horse. It's the most beautiful thing, of course, and there are some things about it that have struck me over the years about what the colors and the shapes of things tell us about the diagnosis of eye disease. We're not going to go into great detail about therapy or anything, because actually, when you think about it, there's very little real therapy that can be applied to the eyes within very tight constraints. There are some conditions that we treat, of course, with great success, and sometimes with a bit less success. But for the most part, treatment of intraocular disease, very disappointing, really. And we're probably 50 years behindhand on the human, where they can translocate retinas and they can do all sorts of stuff in the back of the eye that are quite amazing. We're not in that ballpark at the moment, but part of the fun of ophthalmology is the diagnosis and the fun that you get and the information that you can get simply by looking at the eye. So the color variations and the shape variations are important when you look at the eye. The colors vary with skin color. So some horses have blue eyes, some horses have multicolored eyes, some horses have no eyelid color, some horses have black eyelids, some have pale colored eyelids, and so on and so forth. So there are eyelid color variations, there are conjunctival color variations, and then of course there are intraocular color variations, and this includes the iris, of course the lens, which should be water clear, and the aqueous and vitreous clarity or color. So this is clear, so there's no color to them at all unless there is pathology. So the moment the aqueous becomes cloudy, or the moment the vitreous becomes cloudy, or the lens becomes cloudy, that represents pathology, and it's what that cloudiness is that makes a difference. So you can have blood, so it will be red, or you can have eosinophils, and you may get a different color again. You can have plasma in the back, which turns green. So you can see this is a really visual approach to eye disease. Then, of course, you've got the rather difficult retinal color variations, and those are very difficult because there's an enormous range of different variations, which are variations on the normal theme. So when you're looking at the retina of the horse, are you going to say, well, is this pathology or is it not pathology? And if it's not pathology, is it normal? In other words, whatever normal is, or is it a normal variation on the normal? In which case, the eye is still functioning completely normally. It just doesn't look the same as the classic description of the eye. So this applies to the optic papilla. We'll see some pictures of all this kind of thing in a minute or two. The retinal pigmented epithelium, how much pigment there is, how much tapetum there is, is it normal, is it well pigmented, is it not? And then the non-tapetal fundus, how much pigment there is in that. And if you just look at the pictures here, it gives an illustration of how things vary, and you can see that the color of the iris, the eyelids, the eyelid margins, the lateral limbus, the conjunctiva, all these things have a color pattern that is characteristic for the horse itself. And of course, then you come to the shapes. So whenever you're dealing with an eye, there are mostly circular things in the eye. So things are either circular or nearly circular. I mean, I know the pupil in the resting horse with the part closed eye pupil is not a circle, of course, not like it is in the human, but in the horse it has this very slightly oblong shape with these curved corners on it, which is a very beautiful thing. And then you've got the granular iridica on the top of the eye, which on top of the iris here, but remember there are some on the bottom as well. So here you see these shapes here. These are shapes that have a defined form for a particular horse. Incredible variation in the number, size, shape, location of all these kind of things. And same with the lens, you know, the lens shape and its location matter. And then, of course, the optic papilla at the back, which also matters as to what its shape is, usually round with the blood vessels going all the way around with a little V notch in the bottom. Of course, that's where the optic fissure was when it was developing embryologically. And so there are no blood vessels in that bottom eighth of the diameter of the papilla, and then blood vessels radiate all the way around it into the retina. So when you look at the eyes, of course, you can see that the eyes on this horse are clearly different. So the shape is different. There's something wrong with the shape of the right eye that is noticeably different. And then you say, well, what's wrong with it? And then you have to say, well, which structure has taken on the abnormal shape? Why is it there in the first place? And then is that normal or a normal variant? And if it's pathology, is it pathology of no significance? Is it pathology of equivocal significance? And is it pathology of certain significance? And when you first qualify, everything goes into the equivocal bracket. You know, everything all bucketed into there. And as you get more experience and see more eyes, you start to separate it out into those 5 categories of recognition of what is normal and what is not normal, and then what is pathological and what is not pathological. So as you get older, you realize that things are either pathological or they're not pathological. Then there's a smaller number of things which fit into the middle bracket where they are of equivocal pathology. This is a concept that was shared with me many years ago by a great veterinary ophthalmologist, John Parker. And if he's attending here, all the best, John, and I hope you're keeping well. He was just my God when it came to ophthalmology in those days, because he was a practitioner, still is a practitioner, I think, and still working well. So hopefully he's in touch with people anyway. So horses also have 2 of everything, and here's a little book that my grandchildren had, 2 of everything. But of course, when you've got 2 of everything, they don't necessarily have to be identical. You know, there are certain anatomic differences between this man, this grandpa, and this grandma here, anatomical differences, but there are also differences in behavior, difference in attitude, difference in all sorts of things. The same with the bird, same with the hills, same with everything. So mostly, if you recognize that eyes and the horse has 2 of everything, in particularly in respect of the eye, then it's very important to look at both eyes. There are a few conditions of the eye that affect both eyes identically. And where you see the 2 eyes of the same horse, here they are. This is one eye, this is the other eye, and you can see that this has a very pale iris here and a normal back posterior or temporal half of the iris, very small granular iridica, very small ones here again, but a different pattern of color. Here's a pigmented leading edge of the 3rd eyelid. Here's a 3rd eyelid that's not pigmented. So whilst there are 2 eyes, there can be subtle differences between them, and the same applies to the optic papilla as well. So you can see here there are 2 optic papillas, and they have different shapes, they have different colors, they have different forms, but they are equally functional and equally normal. So why bother with an exact diagnosis in equine ophthalmology? Well, a diagnosis enables us to provide a prognosis, and owners are very often more concerned for a prognosis than they are for anything else. So they want to know, is this going to be all right or is it not? And then, of course, if you say, yes, it's going to be all right, but we have to do this and this and this and this to get it right, then the owners will accept that. If you just say, I'm going to do this and that might get right or it might not get right, the owner doesn't have any confidence in what you're trying to do. So if you get this diagnosis right if you can, and that's why examination of the eye and its imaging and its structure, ultrasound structure, whether it's normal or abnormal, whether it's pathology or whether it's not pathology, are important. Once you've got the diagnosis, you can of course focus your treatment appropriately. So rather than just guesswork, you don't have to just dip into something and say, well, I've got a bottle of this, it'll get that whether it likes it or no. That's a bit counterproductive, and I don't suppose many of us do that at all. And you should never find yourself in that position where you look in your car and you see only one drug and you think, well, can't find the right one, so I'll give it the wrong one. That's, you know, not good, and I'm sure it doesn't happen anymore, but it used to happen quite frequently in the old days when we had very limited resources available to us. Limited therapy options for internal things in the eye, as we said before, very limited to some surgical interferences and some therapeutic things that we can do, of course. But for the most part, there are limited opportunities for treatment. And so the owners want a long-term prognosis, not even just a short-term prognosis. They want to know what's going to happen to the eye in due course. So if the horse has recurrent episodes of uveitis, and of course the changes in the shape of the pupil and the lens and all sorts of other things that go with that strategy or that condition, then the owner, you know, needs some extra information. Say, well, this is not going to go well in the long term, but we're going to look after it in the meantime, and when it gets bad eventually, we will take some appropriate action. So the owners want to know, will it get better? Will it stay the same, or will it get worse? And can you influence those three stages? You want to avoid things getting worse if you can, because the first sign of getting better is, in inverted commas, not getting worse. The diagnostic process when you're coming to an eye, of course, look at all the structures carefully and logically, start with a strategy that is useful for you, and do the same thing every time so nothing gets forgotten. I usually try to look at the adnexal structures first and then gradually work your way into the globe and then through the globe in a logical manner from the outside inwards and then from the inside outwards again, and look at everything as you come out, just in case you've missed something. Remember that there's a nasolacrimal duct as well, which is part of the function of the eye that we often forget. So that's how I work. And if you order to do this, you may need sedation and nerve blocks. Sometimes even general anesthetic helps if you have to do that. You've got lots of equipment to help you. You've got ultrasound scanners. If the eye won't open, you can put a scanner on there, see what's going on underneath. Very, very useful. Just make sure you've got a good quality scanner, because it does make a huge difference. And then establish a problem list in the standard diagnostic manner that we were all taught as students, which we, for the most part, we tend to forget. You know, we tend to pattern recognition and then we jump to conclusions, and jumping to conclusions is not a good thing. You may be right, but you may be wrong. And if you are wrong, you just look a bit of a pumpkin in the end. So, you know, try to consider everything, and before you blurt out what you think is the matter, you know, try to examine everything and think about what the most likely diagnosis is. And if you can't have a diagnosis, then use some aids to find out. So this is just the instruments that you've got available to image the eye visually. So this is the visual appearance. You can shine a light on the horse, see if it blinks its eye. You can look inside with a transilluminator or an ophthalmoscope if you like, or an indirect ophthalmoscope, all the various pieces of equipment which are available to everybody. Just remember, the ophthalmoscope is a sophisticated instrument. It's not a thing to sort of bash about in the back of your car amongst the dust and the boots and the stuff like this. It's a very specialist instrument that is exquisitely made. Just remember, you have to have a bright light. You know, don't try and do this without a bright light. And remember that all the little gadgets and the dials on the eye, on the ophthalmoscope, are there to help you. And if you don't really understand how to use it correctly, then read up about it. There are plenty of presentations on the internet about how to use an ophthalmoscope in horses very efficiently, so that you make the maximum use of it. Fortunately, the eye of the horse is very big, and it gives us plenty of scope to examine it in detail. So just to give you an example here where we've got some changes in the shape and the form of the eyelid. Here we've got the shape changing. So, you know, there's always a horse attached to the eye. So if you look at this eye and you see this, and then you realize, oh, hang on, sorry. And then you realize that this eye is closed and this one is open, and that the horse has also got ancillary problems elsewhere. Just remember that this could be something else. This could be part of a systemic disorder, or part of a general different kind of disease entity altogether. So this is, the kind of thing that we might get in atopy, for example, which is just a congenitally acquired immune condition, allergic condition to certain allergens of one sort or another. And this was exactly the case in point. The horse had been rubbing its eye, so the change of color, the change of shape, and then you look at the rest of the horse and you find that there are other signs associated with it. So when you're wondering what is normal and what's not, always check the other eye. So if you were just to look at this eye, you may say, oh, goodness me, look at the color here, it's all wrong. This is a bad eye. This is the drainage angle here, the insertion of the pectinate ligament. Is that normal? You don't know whether it's normal. The color looks pale. Maybe this has got, leukocoria. It's lost its pigment. In other words, there's danger. But if you look at the other eye and you see a very, very similar pattern, and they're both functioning normally, then it's fine. But of course, look at the iris as well. So you can see that there's a difference in the eyes in the same lighting conditions, in an identical lighting condition. This eye is slightly wider, this eye is slightly smaller. So there's a shape difference and a size difference. So shape, color, and size matter. So check the eyes simultaneously if you can. The normal colors often vary, but the shapes don't show a great deal of variation. So as we said before, there are some things that, change shape. So here's a squamous cell carcinoma. This has changed the shape of the third eyelid. It's changed the shape of the whole fundus. It's changed the shape of the eyelids themselves. This is telling us there's something wrong. Now, it doesn't take any imagination to see that, but in this case, for example, let's look at this, and you see that the pupil is widely dilated here, not artificially, but you can see that the lens is different, and you can see that there's an aphakic area here where there's no lens material. So you can see the pupil is irregular. It's mostly regular, but then there are areas where it becomes very irregular. And of course, that's a shape variation. So we're looking at the iris, we're looking at the conjunctiva, we're looking at the skin color, we're looking at all the structures of the eye in respect of the shape and the color. And that's the conceptual thing that is important. And here you just see an example of the skin color and the conjunctival color. So where the pigment is not present on the leading edge of the third eyelid or on the lateral limbus, they have a very strong tendency towards carcinoma development. So it's not certain that they will get it, but the same applies to here, where you see the color of the eyelid being black and the color of the eyelid being non-pigmented. This gets the carcinoma. This is protected by the black pigment. And this is slides shared to me by Sheila Crispin. And here you see a carcinoma involving the eyelid of this horse. But then when you look closer, you see that the cornea has got a different shape and a different color. So here's a color difference. There's an area of grayness, which is usually associated with cell infiltration, with a white area in the middle, which is usually associated with fibrous tissue and previous ulceration. But actually, this turned out to be a carcinoma directly transferred from here to here. So here's another one. What's going on here? You can see that there's a shape variation. There's a big pink fleshy mass with this leading edge here. This is a prolapsed iris and prolapsed body, which has produced a staphyloma, which has produced granulation tissue from this damage in the cornea. So you can see that there are these variations. So iris variations in normality are very common. Some look very unusual, and you may be mistaken for thinking that there's something wrong, like this one, for example. See the little granular iridica here, there's some here, but there are also some along the lower lid that we tend to forget about. The skin color produces profound differences, of course, in the iris color as well. So where you see cremello horses, they're often associated with blue eyes. Sometimes gray horses associated with blue eyes as well, but not often bay or brown or black horses. Sometimes important because it does happen. So heterochromia iridis is quite common, actually. These are variations between the left and the right eyes. And it makes it difficult under these circumstances to tell what is normal and what is abnormal. And then, of course, there's the fundic variations in normality as well. They can look very alarming, and sometimes they are pathological. So this is a pathological change. This is a pathological change. Here you see the normal fundic appearance, the greenish bluish color of the tapetal fundus and the brownish dark brown color of the non-tapetal fundus. And of course, that makes the optic papilla much more obvious. It also enables you to see the blood vessels that cross the boundary. So if you look in the eye and you see this kind of thing, you might say, well, this is in the non-tapetal fundus. You can see that there are color variations. You can see this should be uniformly brown, but it isn't. There's white areas in the middle of it. These are areas of scarring of the retina and changes. It's a retinal or chorioretinitis, old lesions, scarred lesions. But of course, they are always important. And the same applies in this case. So where you see this green reflection that will come up, hopefully, oh, hang on, I don't know why that's showing so short, but you can see it, oh, it's got a green color to it. And where that happens, it's usually associated with some form of plasma leakage into the back of the eye. So this is the normal eye that you see here. You can record this yourself on your smartphone. All you need to do is to dim down the light or have a rheostat on your light, and you can record these kind of images very easily with your phone. But you can see the non-tapetal fundus here has a lot of damage, chorioretinitis, old lesions, maybe significant, maybe they're not. Remember, is it normal or is it a normal variant? Question one. Question two, is it pathology? And if it is pathology, is it certainly significant or certainly or not significant at all, or whether it is equivocal? I don't know, and you may make that decision. No shame in it at all, absolutely not. 90% of cases that we see, we don't really know what's going on, and it's very difficult to be absolutely certain, categorically certain what you're looking at. Some eye pathology is very obvious, like the ones we're showing you here. These are very obvious, and these are very obvious, provided, of course, you look. There are normal fundic variations, of course, and some of these are very obvious. This is a normal fundus here. This is a normal fundus in an albinotic horse. But you can see the optic papilla is not circular in this case. It's slightly flattened and ovoid. Here's another one. This is normal, but you can see that this area here has got this gray appearance. Of course, that's just myelin extruded out along the nerves that are going into the back of the retina. So this is normal, but it's a normal variant. So you can easily mistake that for pathology. But of course, when you see this, you know that these areas are pathological. So here's another pathology. This is definitely pathological. You can see that the optic papilla is no longer the correct shape. It's got an irregular shape. It's not circular. The blood vessels are not present. So there's a lot of color variations. There's a lot of size variation, and there's a lot of shape variation. The same applies here. You can see the papilla is normal, but then there's no blood vessels coming out of this area. This area is abnormal. Why? Because it's abnormal color. And an abnormal color is usually associated with pathology, not to be mistaken for this, where there's simply no a pigmented color, no color within the tapetum or the non-tapetum or the retinal pigmented epithelium. Still there, of course, and the eye is completely functional, but it is not the same as this one, for example. This one is a detached retina. You can see that the optic disc is no longer clear. There's a color variation with its greenish color inside the vitreous, and there's a shape variation. The pupil is very widely dilated, and of course there are shapes inside. So the color is abnormal, it's cloudy, you can't see the optic papilla clearly at all, as you can see, detached retina. So there's another one just to show you, just to emphasize the point that sometimes you see this kind of extensive areas of retinopathy. And when you see that, you have to look at the blood vessels. You see there are far fewer blood vessels here, and therefore most likely this is pathology, and most likely it is pathology of certain significance. The same with this, the same with this, the same with this, and the same with this. This normal variant, but mostly people would put that in the category of equivocal pathology. Is it pathology? find a friend and ask them, refer it to somebody, send it to somebody, take the photograph and refer it off to some colleague of yours who you knows something about the eye, and they will just say, oh, that's quite normal, that's okay, don't worry about it. Okay, and we all feel slightly uncomfortable doing that, don't we? Because it's our signature on the purchase examination form or whatever it is. So if you keep the picture and record it, even put it into the file for the horse, that's good. Making a mistake is not a crime. It's not a crime. Not seeing it is the crime. You can call it whatever you like. You can say, oh, this is attached retina, and that's my opinion. Even though it's not, it doesn't matter. Hopefully you don't make that same mistake twice, because the next person to see it says, no, it isn't, it's just quite normal. And then, you feel slightly uncomfortable with that. But that's part of the learning experience. I've made lots of mistakes, probably far more than the rest of the audience put together in my life. But I hope I don't make the same mistake twice, or if I make it twice, I certainly don't make it 3 times. Well, if I make it 3 times, maybe I'll try not to make it a 4th time. We all go through this. Anyway, thank you, Dennis, for some of these pictures. So this is just the normal appearance, just to show you again the shape. But look at this area. See, now the question is that normal? Is it a normal variant? Well, actually, it's a normal variant. It's completely normal. It's just that there's a shape variation in the boundary, the equator between the tapetal and the non-tapetal fundus. It's quite normal. You commonly see this sort of hourglass appearance, which goes up in this, and that's something that you should look at. Then again, you see pathology, and you can see that clearly these are definitely pathological changes. There's no question about it. And here you see pathological change, but it's circular. Okay, it's a little astrocytoma. This is proliferative optic neuropathy, but look at the shape of the optic disc, and then look at the area around and about. There's a shape difference, there's a color difference. It's a very obvious change. And there's something extra as well, which is also round. Sometimes they're not round, sometimes there's multiple of them. And then when you look at the optic papilla and you see this is a suppurative optic neuropathy. So this is pus pouring out from the optic papilla into the vitreous, and that's not the greatest thing in the world. The pupil is widely dilated. Why? Because it's blind, and it's a suppurative optic neuritis, and it's a very dangerous condition, of course. And again, how do you treat this? Well, you can't really. You just have to accept that it's going to probably compromise the eye and make it blind. Well, actually, if it's both eyes, there's a problem, because this is not going anywhere. In fact, this horse did have both eyes affected in this way. You can see these pus balls come boiling out of here into the vitreous. And of course, you lose sight of the fundus itself, because the vitreous becomes cloudy, starts to take on a different shape. Instead of being a color, instead of being clear, it tends to be a very cloudy appearance. So remember that the structures of the eye talk to each other. So when you have some pathology in one eye, the other eye will often respond to some extent in the other with a change of some description. So the primary pathology is the big issue, because sometimes if you look at one eye, so that looks, as though that's also affected, but actually it may be secondary to the fact that there's pathology in the other eye. The types of pathology, remember to differentiate from normal variants, and that's the biggest problem of all. So here we have this category of our interpretation of the findings. Great basic principle propounded by John Parker for many years. Interpret the findings and find out what you think is normal. Establish what's normal, find out what's a normal variant, and then establish whether there's pathology of no significance, equivocal significance, and certain significance. And that applies to all the structures of the eye, the anatomic and the color variations, shape variations, color variations. So here you see an eye that ostensibly looks normal enough, except for what's going on here. And you can see that that's abnormal. So then, of course, you look at the eye, you see, oh, hang on, there's something happened here as well. So there's been something going on here. And there's a scar here, which changes the shape of the lateral canthus of the eye. And of course, you can say, therefore, that this may have been associated with this. And then you find the history. Oh, yes, he had a very bad cut here, and he actually lacerated his cornea in this area that had required surgery to repair. So then you can say, right, well, at least we understand it. Is that pathology? Yes, certainly pathology. Is it pathology of significance? Probably not by now, because it happened some years previously and the horse has been completely normal since. Therefore, it's not even equivocal. It's probably of no significance. So if you say that this is pathology of no significance, we would always add the word probably, simply to protect yourself a little bit. So if you say this is probably therefore of no significance at the moment. Some things, the pathology, of course, when you got the color and shape, are definitely abnormal. So here you see a foreign body, which is a brown color for a start, and it's changed, and it's a different shape from what we would expect to see. There's yellow here, which represents plasma in the cornea, white and blue, blue meaning edema, white meaning scar tissue, yellow meaning pus, and red meaning blood. So those are the things that happen here, and you may see black as well if the cornea is ulcerated and there's an iris prolapse, or there's no iris prolapse, but it's just down to the Descemet's membrane, in which case you'll see the black area. But of course, again, here's a slightly blue eye. And if you can see, there are little areas of white in amongst it. So here you see white areas which represent fibrosis or cellular infiltration of I don't quite know what's happened here. I just need to hit the Alt tab. Okay, that's it. I hope I'm back now. So I'm sorry about that. I don't know what happened there. Somebody muted me. Okay, so anyway, so here you see this, and you see here that there's red. So now we've got red meaning blood. We've got blue meaning edema. We've got white meaning cellular infiltrate, and that's telling us something about the pathology that's going on here. It's a case of herpes virus keratitis. So here you see this edema here. This is definitely bluish. It's got a tendency to blue anyway. It's representative of corneal edema, and you can see the pattern which we see here is very characteristic of this particular kind of endothelial change. And this is endotheliitis, and it's a very serious condition. When you see this kind of pattern of edema, you have to ask, what's causing this? If it's coming from inside the eye, be very careful, because the chances of saving this eye in the end are not high in my experience. So, but if it's of course being caused by an entropion or a foreign body or edema or caused by ulceration or whatever, then that's something quite different. Here you see all the other things. So now we've got a black pigment here. We've got yellow and white, as well as distortion of the cornea. So the shape of the cornea here is wrong. And you can tell that from the flash of the photograph. So when you see this, you can see that there's a reverberation here. The reflection is not normal. It's not a nice sharp reflection, which should be coming off the surface of an intact, normally shaped cornea. This is abnormal shape of the cornea, it's abnormal pigments, it's abnormal colors. So all three things are present here. Same applies here. Look here, we've got something here which may or may not be pathological. It's a little nevus, I think. So here you've got another little nevus here, little black, brown pigmented areas of change of color. So they don't always have to be black. I don't know why it keeps doing this, but you can see this flash. You see this, I mentioned that business about the flash, because that indicates that the cornea has got a nice shape. But here we see granular iridica, but these are huge. So the shape is different. And furthermore, this one here is very rounded. This is a cystic granular iridica. So that's a little bit different from the normal granular iridica, which have a more floppy kind of a shape. And you know, these are variations on a theme of color and shape. And here you see here another little shape change and another shape change here. And of course, the pectinate ligament insertion, the drainage angle here, very wide and abnormal, and that's abnormal. So this is not the normal state. So look at the other eye and see what's normal, or look at another horse and see what's normal. And then you may say, well, this is abnormal, so maybe this color is also abnormal in this particular horse. It's a pale colored horse, so maybe it is, maybe it isn't. But look at the other eye and just get a general impression of it as to whether that's the case. So here you see different colors again. So this is horse got two eyes, of course. We look at the good eye first. We see the granular iridica here along the upper lid. There's a few on the lower lid, which are much smaller. The shape of the pupil is more or less normal. And the pupillary portion of the iris, as well as the ciliary portion, are normal, but non-pigmented. Here you can see right through this, of course, if you shine a very bright light at it, because there's no bulk to it, there's no pigment within it as well. So there's no pigment in the epithelium of the iris. So here you see the changes which happen in this eye over a matter of 3 days. So this is day 1, day 2, and day 3, and you can see the change in color. So here you see the change in shape because the cornea is not normal in any of these cases, but you can see that aqueous is cloudy. The iris has completely lost its pigment. So this was a blue eye like this, but it's become yellow and it's become rather ugly looking. You can see the difference. And here you see the pupillary portion of the iris is very closed in. The pupil is completely constricted. Then it starts to go red. Now we get blood. So as soon as we get blood, we start to accumulate blood inside the eye. And then we have to try to explain why this is coming about. This is just a case of ocular leptospirosis, a very acute ocular leptospirosis, a very difficult condition to diagnose and very difficult to treat. But it just illustrates the color variations that can take place even within one eye over a matter of days. So here again, color variations occurring naturally. Subtle color variations can be pathologic. So as we showed you earlier on, when you see the cornea, the iris that starts to lose color, it starts to become leucochoric. In other words, the pigment is going, and that's not normal. The pigment should remain, it should not change. But of course, there are lots of normal variations, and that's important for us to detect. Of course, the summary of what this section says is that color really matters. And if you look at the color of something, you get the idea as to what could be going wrong. What is the pathology? And then you have to make a decision as to what that might be a consequence of in terms of disease. So what about the shape? Well, the shape, of course, matters as well. So here you see the shape of this corneal edema. See, it's blue. And you can see that the pectinate ligament, the drainage angle here is very irregular. There are areas of white areas within the cornea, these striae here, which are representative of Harb's striae, which are tension tears, I suppose, within the basement, the endothelium of the cornea. So you can see those, and that means that the pressure's been high at some point in the past. So this has had glaucoma. But then when you look inside the eye, you see that the lens is the wrong color, the iris is the wrong shape, and the lens is out of position because there's an area of aphakic appearance just in the medial, on the nasal quarter of the pupil as well. So there's no lens there. So that's not normal. So of course, then you can have a look with your ophthalmoscope. You can use your phonioscopy if you like. You can use your telephone. Your telephone is a good ophthalmoscope. You know, don't worry about that. You can get a lot of information from your telephone if you set the thing up correctly to take the right thing. You can measure the pressures of the eye. You can look at it with a slit lamp and see where things are in the anterior part of the eye. You can do ultrasonography, which is very sophisticated because you can see the lens. You know where the cataract is. You know how big it is. This is an abnormal lens because it's very spherical. It's got a very spherical appearance, and that's not normal for a horse's lens. This is a much more normal shape with its cortex and its nucleus in the middle. That's an MRI, of course, and that's not available to many of us in any case. So here you see a really pranged up eye. There's no other word that you can say for that. There's a lot of changes in shape, a lot of changes in color, and of course there's a lot of pathology in here. Is this eye normal? No. Is it pathology? Yes. Is it pathology of significance? Absolutely. And the same applies here. So is this normal? No, it isn't. This may be normal, but this is definitely not. Is this pathology? Yes. Is it pathology of certain significance? Absolutely. It's not even equivocal. There's no debate about any of these eyes here. So, this seems to have a mind of its own tonight. Okay. The external eyelid appearance matters. So remember that where you see a failure, a loss of the shape, the normal shape and positioning. So this is a case of entropion here in a young foal. And that's abnormal because the eyelid does not have the correct shape. It doesn't have the correct function. And of course, it leads to corneal ulceration or corneal inflammatory change with consequent edema and change to a blue or even a pale gray colored cornea. So, and of course, if you stain it, you might even see an ulcer. So you can establish this very easily. The same applies to this kind of thing where we see changes in shape of the eyelid itself. And then here you see a case that's had a huge accident at some point in the past. He's caused a massive damage to the eye. The eye is not the same size. It's not the same shape. It's not the same color, and it's non-functional as well. So is this pathology? Yes. Is it pathology of significance? Yes, but it probably isn't of significance anymore because this is a very stable eye. So maybe this has just been sat there for 5 years or maybe longer than that in this case, as I recall. And that has been there for 15 or 20 years since it had its accident and hasn't changed at all. So maybe this is definite pathology, but it is no longer of any significance in itself at the moment, at least. So you can have the eyelash variations, of course. You can have abnormal position of eyelashes. You can have variations in eyelid position as a consequence of Horner's syndrome, where the eyelid drops down, closing the palpebral fissure, so that even the shape of the palpebral fissure can help you to some extent. Eyelid and conjunctival changes. So you see this horse was presented like this, and we noticed that this horse was slamming its eye closed and was pulling the eye back into the socket. And then when we looked at it, of course it had a discharge, so the color was abnormal. The eyelids were thickened. The lower eyelid was very edematous, but the upper one was very thin and had this rather strange crenated shape in it. And when we looked underneath, we could see this little brown area here and another little brown area underneath here. And what did we find? We find a stick inside. And when we found a stick inside, we went back and found a second stick inside immediately adjacent to it. So look very carefully, because there are subtle changes that will enable you to see what is going on and what is normal. And of course, we can also change the color to our advantage by putting the fluorescein or rose bengal on these eyes. And here you see an ulcer stained with fluorescein. It's not a great way to do it. You should flush out the excess fluorescein. But if you look here, there's been a problem here. This horse had an upper eyelid laceration, which was repaired, and had a exposed piece of suture material in here that was grinding away on the cornea down here. So the horse kept its eye closed and wouldn't blink its eye. We paralyzed that and had to look and stained the eye. You can wash all this extra fluorescein out. It helps a lot. When you do that, you get this kind of appearance. And of course, that is clearly an ulcer, and it enables us to see the shape of the ulcer. Does that mean anything? In some cases it does. And as in this case, we were able then to say, oh, hang on, there has to be something under the upper eyelid. And then we look under the eyelid, and there we see the problem, and we sort the problem, and the ulcer goes away. It's as simple as that. But here you see the consequence of staining with rose bengal, and ulcers that stain positive with fluorescein and rose bengal are dangerous. In my experience, they are dangerous, and that's because the precorneal tear film, I beg your pardon, is not sticking to the exposed corneal stroma here. So if that doesn't protect it, then it's difficult for the epithelium to go over, and it becomes more liable to infection and ulceration and melting. So here's our cases again. So shape, eyelid position, blue, yellow, red, the yellow being plasma or pus, sometimes plasma. Brown meaning infiltration of cells of some sort. But again, this color and the shape matter, and the position of the eyelids matter. So here's our case, which we showed you before, so we'll skip past that. So here we see another set of shapes. Here's the ectropion. So here's ectropion, which you can see the eyelid is drooping, very low and long, congenital abnormality that this horse had for some years. We were able, of course, to remove the central portion and just bring that up to there, and then close this here. This is where the nasolacrimal duct is here, so got to be careful that you don't mess that up, because it's draining from there downwards into the lacrimal sac and then down the nose to the nasal cavity, of course. So here you see the cornea again. See the sharp reflection is very good. So here you see these. This is distichiasis, as you see here, and you can see that there's eyelashes which are stroking the cornea. What's that doing to the cornea? Well, it's making it edematous. What color does that go? That goes blue. And that's what you land up with. And of course, this horse had long-term medication for an infected eye. And then when you look at it closely, this is what you see. Of course, that has to be removed. Same with this. Here's a few little hairs which are sitting on the leading edge of the third eyelid, and everything else looks normal, but the horse had a persistent, mildly painful eye, and this has had all sorts of treatment, but nobody had actually looked closely at this particular portion. And you can see these little hairs sticking out here. There's one here. There were a whole row of them, actually. These are sorry, this is trichiasis, this is distichiasis, abnormal location where there should be none. Here's an entropion again, just like we had before. Here's a little kink in the lower eyelid. Now, is that pathology? Look at the cornea, look at the iris, is that normal? Well, look at the other eye. You know, everything else looks normal, although the iris just looks terrible to me, but actually both eyes were identical. The reflection is normal, but it does have a small cataract, some opacity within the lens, and you can identify that because of the change of color. The visual media should be completely water clear and should not have any changes within it at all. Same thing applies to the eyelid. So we've got lots of conditions here. Sarcoids, of course, I can't show a presentation without some sarcoids in it. But here's some tumors here as well. Are they tumors? Well, yes, they are. But what about the granular iridica? But the cornea is normal. So shapes matter, color matters, and size matters. Here's inflammation. Of course, the shape has changed, the color has changed, the cornea has changed, the pus has changed, the eyelid has changed. So there's lots of shape and color changes going on here. See the little cataract on the anterior pole here. This is a mast cell tumor on the third eyelid. Looks like a squamous cell carcinoma, but isn't. It's a mast cell tumor. And again, the shape matters. The shape has changed. The third eyelid is not normal, and the color has changed. So you've got that yellowish appearance, which is very characteristic of mast cell tumor in this location. Lymphoma. Oh, yeah, hang on. Let's go back here. These are. Will behave itself. So here you see lymphoma lesions within the conjunctiva. How you owner noticed these, I don't know, but she noticed them, and they were abnormal shape because it presented with an abnormal location and shape of the third eyelid. Didn't function quite normally, and the owner noticed that very quickly. Same thing applies here. This is not dramatic, you know, so there's nothing much you can do with this. A squamous cell carcinoma filling the whole orbit of the eye from a neglected squamous cell carcinoma, pranged the eye, lots of color changes, lots of shape changes, all the bad things. Same thing applies here, of course, and of course, same thing applies here. Color variations. The conjunctiva shouldn't be black, and it shouldn't be well demarcated like this. This is a melanoma on the conjunctiva. So here we see it again, shape changes again. These could be collagen granulomas, which they actually were, or they could be impacted meibomian glands. They could be sarcoids, they could be melanomas, it could be lymphomas, all those things. Here we see change variations. This horse was presented with a blue eye. It had edema of the cornea and positive on fluorescein stain. And of course, it had long-term involvement of this. So it had lots and lots of corneal treatment for ulceration with antibiotics and all sorts of things. But actually, it had a mast cell tumor underneath the upper eyelid. And of course, unless you remove that, this cornea is not going to go back to normal. Here you see a horse that's got the full Monty. You see a melanoma changing the shape of the upper and lower eyelids and altering the function of the nasolacrimal duct. Here you see a sarcoid in the corner of the eye, and here you see a carcinoma of the lower lid, all altering shapes and sizes and colors. So you can see the color here is black, the color here is fleshy. Doesn't mean if it's fleshy that it's not a melanoma, because you can have an amelanotic melanoma and you can have a melanotic sarcoid. So you just got to be a bit careful. But usually these are quite easily diagnosed. When you see red like this, it's blood. and this is a hemangioma or hemangiosarcoma of the conjunctiva, a very dangerous tumor type. So you can see that that's where that is. So corneal changes in color pattern. So you see this is the normal reflection here and the normal drainage angle, which should be like brackets on the side of the eye. And then of course you see the variations where things turn blue, where things change in color. And then you see this fibrosis which occurs here. So this is blue edema plus cell infiltration. So remember, you can change the color to your advantage. So that's one of the things that you can do. And this is the fluorescein tear film breakup time. So this is the fluorescein. The fluorescein is there, and the lids are held open. This is Dennis Brooks's video, and you can see this. And when you mix this up, it should flow down nice and smoothly. But actually, this is the normal bit at the top, and it should take 10 seconds for this appearance in the ventral cornea to occur. So this is abnormal. So you can change the color to your advantage. But here you see some good color charts. Okay, so where is it? What structure is involved? Here's white on the cornea. That's corneal scarring. Of course, there's a change in the reflection of the flash. Here you see white. This is cellular infiltration. This is a carcinoma in situ of the cornea here, occupying this. Of course, there's red as well, because that's blood vessels. So here you see eosinophilic, I beg your pardon, this is lymphoma. This is corneal lymphoma. And you can see that there's a lot of cellular infiltration with a lot of blood in it. So this is cells. So as soon as you see this, there's cells. Here you see yellow, which is usually consistent with pus. And here you see the immune-mediated keratopathy, which is associated with a brownish color in most cases. So you see the flash is normal, but the color in the cornea is not. So this is a stromal interstitial immune-mediated keratopathy. And so here you see the same when you've stained those kind of eyes with rose bengal, and you can see that there's an abnormal cornea and an abnormal color to your advantages. So remember, blue is corneal edema, white is cells, yellow is pus, brown and green are immune reactions of some description, brown or black is a foreign body or a decimetocele, okay, or iris prolapse, because that's a dangerous thing to see. And then of course you can have red, meaning vascularity or hemorrhage, just like we saw in the case of the acute leptospirosis. So you can see that these colors do matter. So here's some pattern changes. So here's the blue, as you can see, mostly associated uniformly like this, usually with increased intraocular pressure glaucoma. Here you see areas of change of pigmentation, and you can see this linear keratopathy running across the eye. I just don't think these are pathological. Some people would disagree with me, but that's quite different from the striae that develop as a consequence of chronic glaucoma, where they start getting these tears within the corneal endothelium. And here you see another one of these single straight line going across. This horse had this for years and it didn't alter at all. This, of course, is the immune-mediated keratopathy we showed you a minute ago. And you can see it has that brown appearance, which is really, I suppose, plasma and protein leakage into the cornea. And of course, there's a lot of blood vessels associated with it. In this case, there's an ulcer here as well. So you can see that this is the color change. This is this linear keratopathy, and this is a slide from Dennis Brooks, which just illustrates the point. So this is the epithelium, this is the stroma, this is the endothelium here, and this you can see here is just an absent part of the endothelium. It's completely normal. There's no inflammation associated with it. It's very cut off, and I think that's probably just a congenital abnormality that occurs from time to time. Some people would disagree and think it's pathological. So you can answer that question. Is it pathological or is it equivocal pathology? So you may say one or the other. Here's some corneal edema again. Here's some red, meaning inflammatory changes. Here's the black and brown and white associated with a chronic mushed up eye, for want of any better description of it. Of course, looking for this horse had a beautiful brown eye, then it developed uveitis and significant pathology in the back. It was more or less blind in the eye, pupil was widely dilated, but of course it had lost pigment here. So this is a pathological change in the color of the iris. Here you see scarring. So here you see scarring, but also you see opacity and yellowing or whitening of the lens itself. So you can see the cornea is not normal here, as shown by the reflection. But these are the two. This is the two. There are two eyes here with a slightly different appearance. And as you can see right into the back of the eye, but you can't see detail. So there's opacity there in the lens, and there's also opacity in the cornea here. Some areas of much more aggressive opacity or whitening here with scarring. The color, texture, and pattern variations from normal. This is a typical appearance of a fungal keratopathy, a fungal ulcer, very dangerous, has this fungal appearance. I don't know how to describe it really, but it has this very characteristic appearance of a fungus growing on your jam. If you open the jam, if you make your own, you see this kind of thing growing on the top of it. Very dangerous state of affairs with a lot of inflammatory response being red. So red is blood, red means increased blood and therefore inflammation. So here you see white in this very difficult, this is keratic precipitates in the eye. You can see these areas, but they're very highly vascularized, as you can see. So there's red, white, green, gray, brown, all sorts of colors in this kind of eye. Here you see an eye that's where the horse has got a chronic glaucomatous change with a lot of pathology in the cornea, starts to go blue first and then starts to pale as the cell infiltrate starts to take on, and then the tears would normally take place, which would result in those scars that are characteristic of chronic glaucoma. Here's a black area which represents a decimetocele. You can change the color. Of course, as usual, as we said before, so you can use that. There's a little black area. See, is that normal? No, this eye normal? No, I don't think so. It's abnormal. Is it pathology? Absolutely. Is it pathology of significance? Absolutely. Why? Because there's something wrong here. Okay, could be a foreign body, could be a little puncture of the eye. In fact, that is exactly what it was. And there's a puncture through there, and a little bit of the iris has floated back and blocked it up. But that's fortunate, I suppose. But there's an ulcer here as well, so you can use this to diagnose it, but also look at the shape of the flash, because that's also helping you, the shape and the texture and the appearance of the drainage angle medially and laterally as well. So here you see ulcers with shapes vary. Okay, so ulcers vary in shape and size. That may tell you something about where it is and what it's happening, but you can enhance this very strongly. Blood, of course, is always red, and you can see the blood coming in here, that's red, but you see the black area of this perforating ulcer, it's just got decimase membrane here, that's all that's left. But it's been trying to heal, and it's been going for weeks, as you can see. So it's been going and going and going, and now finally it's let go. So be very careful. Superficial neovascularization comes from the surface and usually means a surface problem. Deep neovascularization comes from underneath, and you can't see it crossing the limbus because it just suddenly appears all the way around, and that's usually associated with some deep corneal problem or endothelial problem. Here's our case that we showed you before, just to show these little white areas. You see the generally blue eye, generally slightly edematous, but with these focal areas of cellular infiltration, usually associated with herpes virus infection. There's another one that's very similar. Here's edema again, but look at the shape of the eye. This is a decimetocele here with a just sitting there waiting to pop. This is a chronic change as a consequence of radiation around the eye. So this had a keratopathy, a radiation-induced keratopathy, and a radiation-induced uveitis, and a radiation-induced lens opacity cataract. Here you see a big ulcer with blue and a black area in the middle. So again, the color shows very clearly. Here's chronic changes in the eye that result in pigmented keratopathy, very chronic changes which happen, and it allows the black pigment to traipse across the surface of the eye. Used to be very aggressive, then it's calmed down, and has it now become normal? No, it hasn't, because there's still edema around, there's still white areas, there's still the black areas, as you can see, and the reflection is not normal. So the cornea is not normal. It can't be construed to be normal. Pattern of edema helps, so you may see edema around an ulcer, of course, like this. There's a little puncture here, of course, and you can see here that this is a normal eye with, as far as the reflection is concerned, but the pattern of edema is low down here, and usually associated with something on the surface of the eye. Here we see another case which shows the same kind of changes. Here you see the green at the back. Green at the back usually means posterior uveitis, and then you see corneal dropsy, and you can see that here you see the edema of the cornea with its running down, and that's really why there's a lot of green within the cornea as well. So this is a really dangerous eye with a lot of pathology in it, with bluing of the cornea, as you can see here. So that's edema plus plasma infiltration in the cornea, plus plasma infiltration in the vitreous and posterior segment. Endotheliitis produces these kind of patterns of corneal edema like this, resulting from block of the endothelium, usually protein deposits on the endothelium, usually a very bad sign when you see this kind of pattern of edema. Eosinophilic keratitis has a very characteristic appearance, sometimes sort of kind of bluey color, orangey color like this, or yellow, sometimes fleshy like this, with a almost like a translucent yellow color to it. And the same applies here, sometimes proliferative as well. There it is again, another one. This is a corneal laceration that had a suture in it, as you saw, and of course it's resulted in a significant scarring here. So it's red, white, blue, and yellow, plus blue over the whole eye like this. Okay, so that, and there's a lot of blood here, so this is abnormal. Here you see an ulcer stained, again, the same thing again. Here you see carcinoma of a varying description, or tumors. Here you see this opacity here like this, and then you see the fleshy appearance. But of course, if you look at the back of the eye, you get that red, that green appearance like that. Be very careful when you see that. Here you see these shapes here and the color variations of mast cell tumors, of course. So this is all part of the same process. You can see the color shapes matter within the eye, and you can see what happens as a consequence of that. Corneal carcinoma in situ that you can remove, that's okay. Iris and anterior segment changes, blood, you got blood in here, that's red, it's blood. Where did the blood come from and why? Blunt trauma here, sharp trauma here, corneal edema, all the associated problems associated with it. The same applies here with a cyst. This is a cyst, this is a cyst. Is this pathology? No. Is it significant? Well, some people think it is. This one significant? No. Is this significant? No. Iris hypoplasia, insignificant. Is this significant? Possibly, because of melanoma of the cornea, of the iris. So what I'm trying to tell you really is that when you're looking at an eye, you have to really understand that the colors and shapes really matter, because they do tell you a lot about the eye. So I'm going to stop now because I see we've run out of our hour. And I would like to ask to put some questions if anyone has any questions to it. It's a difficult, just a different concept and a different way of looking at the eye that I think you may find useful when you come to deal with your eye cases. Thank you very much for your attention.
Derek, I'd just like to say thank you on behalf of all of the audience who are unable to speak. They're all muted, so I'll do it for them to say thank you. That was a superb presentation. We do have several questions to get through. So in the spirit of time, I'll crack on.
Yeah, no, that's fine.
First of all, question: what was the diagnosis here in this case with this horse? Now, based on timing, because there's not much detail given there, I think that case was the ocular leptospirosis, probably.
Yes. Yes. I think what you can say, yeah, and what you can say with this is that there's uveitis. You know, this has got a patent uveitis. The pupil is very constricted, very tight down. The cornea is not normal because the flash is not normal. You can see that the pupil is changed in color. So this is almost certainly associated with a very potent uveitic change and a very acute onset. If you left this, there was plasma that accumulated here. There was a prominent aqueous flare. If you looked at with a slit lamp, it was virtually, you could just see the swirling of the protein matter. There should be none of that. Of course, you'd be water clear. Couldn't see in the back of the eye. We had to put a scanner on this to see if everything was right in the back. There was a lot of accumulation of debris in the back of the eye and a partial retinal detachment as well. So that's why the scanner matters. When you put a scanner on these eyes, when you can't see anything beyond this, try to use all the skills that you have to try to do it. You want to get to know whether this eye is visual, shine a very bright light. Use a single little LED light and shine a very bright light in this eye and look at the pupil on the other eye and see if it constricts. If it constricts, you've got to fight for the eye. If it doesn't, well, you may be praying the eye completely and you won't get very much out of that.
Sure. Thank you, Derek. Okay, so I'll try and address the rest a little bit in order as they came in. So first of all, maybe a stupid question. I can answer that part. No, it's not. Is cortisol ointment still contraindicated on corneal ulcers? Human ophthalmologists don't see this as a problem.
No.
That seems to be.
Yeah, I think there's a lot of debate about this, and I mean I believe there's a place for it, because actually you have to understand why the melting occurs, why the collagenolysis occurs, you know, why the cornea just melts away. That's as a consequence of collagenase enzymes, which are secreted by two things: one, bacteria, and you have to get rid of those, and effete neutrophils. Mostly. So of course there's some sense in saying, well, just every now and again, you know, you can justifiably use a corticosteroid on an ulcer. You just got to be very careful that there's no patent infection, because otherwise you will melt the eye very quickly indeed, and particularly if it's a fungal infection. That's hideous for that, because it just lets the fungus go, takes away all the immune responses and gets rid of that, and the bacteria just say thanks very much, or the fungus says thanks very much, we're just going to eat the eye, and that's what happens. So be very careful if you're going to do it, and I would strongly suggest that under no circumstances should it be done when the horse is outside a hospital circumstance. I think I know from personal experience, they gave me steroid when I had an ulcer, and I said, I don't want the steroid. They said, no, put it in. And sure enough, the following day, I felt very comfortable, and the ulcer healed beautifully. So I think in humans, they have a slightly different kind of problem, and they do tend to use it much more for that reason, that there's logic in suppressing the inflammatory response, because that may be leading to the collagenase enzymes being produced. You know, this melting thing is a serious thing in horses. Once it starts, it's hideous. And you know, once it starts, you say, well, it's starting, so we better stop it quickly. Well, then you've got to have anti-collagenase systems, you know, acetylcholine, you know, plasma, you know, all these kind of things that you can use. EDTA you can use, and those will help to suppress that process. So be careful. Just my best advice is to say, as a general rule, you shouldn't use it, but occasionally it can be helpful. I'm sorry, that may be contentious amongst ophthalmologists, but that's my opinion, and I've used it in this light with some good successes as well. Yeah.
And fantastic. That's brilliant. So the next one then, which probe is best to use for ocular ultrasound?
Right. Well, it depends what you're looking at, and usually we would use something 10 or 12 megahertz, something above that, if you want detail. The problem is, I mean, modern ultrasound machines are incredibly elegant. They are unbelievable. And I had the privilege of using one of IMV's ones some years ago, and it's staggeringly good compared to when I first started, when there was 1 pixel per kilometer. You know, I mean, it was very difficult to see anything. And now we can see detail of lenses. We can see detail of drainage angles. You can get right the way up to 25 megahertz if you really want. That's going to give you very shallow depth, of course. But the heavier, the lower the kilohertz, the megahertz on it, the more penetration you get, but the less definition. So yeah, most machines these days have variable power, really, and you can adjust that. So you can change from, you know, most go maybe 7.5. You can still get a lot of good images from 7.5 linear scanner. You just put it over the eye, make sure that you get the angles exactly right, and then scan from nasal to temporal, or temporal to nasal, and then from superior to inferior across the meridian. That way you'll get lots of useful information about where things are, whether the lens is present, whether it's luxated posteriorly, whether there's vitreous, whether there's a detached retina, all the things that can show with a really good ultrasound examination. The fact is that you need a modern quality machine, and I think if you're hamstrung by having, you know, a terrible old tatty old machine that's bashed to hell and keeps breaking down in the middle of it all, it's very frustrating. And a good ophthalmic ultrasonographic examination is worth its weight in gold, in my view. You know, where I was always a bit worried about where the cataracts were, what kind of cataracts there were. So I would use it. You know, I like the ultrasound, particularly if the horse has pranged its eye and it won't open its eye. You know, you can just see what's going on. You know, so you can paralyze the upper eyelid. Of course, that's easy enough. But if you scan the eye, you can say, oh, hang on a minute. You know, the anterior segment is completely flat. The lens is out of position. So do we bother? Well, no, you don't. You just remove the eye. You know, that's a big decision to take, but it's the right decision. But if you see everything is normal and the eye is tight closed and won't go, then say, oh, hang on, we're going to fight for this. And then when you get it open, shine a light in the bad eye and watch the pupil on the good eye to see that it constricts. Because if it does, then you've got to fight for the eye. You've got to fight like hell for the eye. And it's amazing what you can do in all these conditions with the limited resources that we have, because the number of conditions we have to deal with very low, and therefore we don't need very much to make some significant progress. Nonetheless, there are things like cataracts and things which require very different management altogether. And you know, cataract surgery is being done. I think Fernando does some, and Rob does some, and several people do them around the UK, and that's very good, because historically there was nobody doing it, and now we've got people who are doing it and putting lenses in. So you can do a lot to help you and help the horses to see.
That's brilliant. Thanks, Derek. And I'd probably add to that, I guess, the key bit being have a linear probe if you can.
Yep.
So absolutely in agreement with Derek's points there. But if you almost frequency irrespective, if you can have a linear probe, even a tendon probe, then that should talk.
Yeah, it is an amazing thing, and you know, I've always been a bit of a fan of a conforming standoff. In other words, so that you have a glove filled with water, even if it's very shallow, so that it conforms, so that you can keep your probe very vertical and you don't have any cutoff around the edges. You get the whole thing in that, and it's amazing how good it can be. It really is amazing. And people see things in the back. Oh my God, look at that! And you realize it's the lens zonules. You know, you can see the pars plicatus. You can see everything. It's beautiful. You just have to get used to doing it in a normal eye first, and then once you've got that, you can start to look at things that make a bit of a difference. So if the lens is slightly out of shape or out of position, you know, partial luxation lenses, you can see those very quickly. You can see, you know, peripheral equatorial cataracts very easily, whereas otherwise you have to look really hard, right with the pupil very widely dilated, in order to see those. And but you know, the scanner will find them straight away. Yeah.
So moving on then, the next one, Derek, in your experience, what's the best way to manage a retinal detachment?
Oh God, go to church on Sunday. It's very difficult. You know, people who have retinal detachments, they have them put back. Of course, you can do that. What they do in the human is they lie you on your side with their thing with the affected eye up, and then they pull back. They put a little needle in the back, and then they suck the plasma out from behind the retina and reseat it, and then peg it back with a laser. And it's quite extraordinary. But you've got to keep the person on its side. You've got to keep the eye very, very still for a long time until the retina sticks back. You know, but the moment it comes off in a horse, no horse is going to tolerate that. They go blind more or less immediately on the eye, and I don't think I don't know of anyone who's actually repaired one in a horse yet. I may be wrong. I'm not very up to that, I suppose. But I prefer to remain a little bit more. I don't know. I think there's a boundary, you know, that I'm not really prepared to cross. And if the one eye detaches, then you still got the other eye, and that's fine. And it doesn't. Sometimes they can have a detached retina, and the eye does not get affected at all. You know, it just looks like a normal eye, but it's completely blind, of course. But if you see that detachment, shine a light in it and see if the other eye functions. You know, sometimes it will function a little bit just for a little while after the acute stage of it, but usually happens after falls and things. But if it happens in both eyes, it's very dangerous, and I don't think there are any effective ways of repairing those. Not to my knowledge, anyway. Maybe I'm a bit old-fashioned, and because I'm not a card-carrying ophthalmologist at all, of course. Yeah.
Yeah, that's fair. Next question, Derek, is what is the best way to diagnose a uveitis? I think we possibly touched on that a little bit there with that last case, but
yeah. Well, it depends what kind of uveitis you're talking about, and if you're talking about the so-called equine immune-mediated or recurrent uveitis, I prefer to call them persistent uveitis. These are it's a question of making a panel of clinical signs that are consistent with it. And of course, we think of, you know, of blepharospasm, photophobia, meiosis, pupil constriction, aqueous flare, you know, vitreous flare, possibly, those kind of things all combined together. And then more latterly, some changes in the iris color, the changes in the iris position, adhesions either to the lens or to the cornea, posterior anterior synechia, for example, those kind of changes, which represent the more chronic changes of it. But if you see painful eye, and the pupil is very strongly constricted, and you've got aqueous flare, and there's no other explanation for it, no trauma and so on and so forth, which can also cause it. I mean, a lot of people say, well, if a horse gets corneal ulcer, then it gets uveitis. I don't believe that. I believe that's a reflex meiosis. So that's quite different, and the iris is quite normal, and it does dilate with atropine. Sometimes when you get them very bad, they don't change with atropine. They just sit there. You know, that's the dangerous state of affairs in my view. They have to dilate, you know, and you have to get them wide. So if they do that, and then you can measure the intraocular pressure if you're privileged enough to have a tonometer of some description. Don't use the little Tonovet one. I didn't get on with that. I think it's so inconsistent. The rebound one, which is the Tonovet, and the Tonovet Plus is very accurate because it's got a little light that tells you in your right position. Then you press the button and it just goes dip, 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 takes 5 readings straight away and averages them out for you. So if uveitis, the pressure is low. So rather than 19 to 23 or whatever it is on that particular horse, take the good eye first, measure the pressure, and then you find this is 9 or 8 or something. And actually the eye looks soft, because that's because the aqueous is not being produced properly. Of course, the cornea will go blue. Why? Because just like mastitis causes abnormal milk, uveitis causes abnormal aqueous, which doesn't nourish the endothelium. So you get uniformly blue eye, even though the pressure is low. So, but of course, if it's high, then you get uniform blueness as well from glaucoma. So that's end stage uveitis. So the diagnosis of uveitis, as a general principle, is relatively easy, because you can say it has uveitis, and therefore you have to try to find the cause of that. You have to take it one step further and say, right, now, what kind of uveitis have we got here? You know, is this going to respond to corticosteroids? Is it going to respond to methotrexate? Or what do you need to do in order to treat the uveitis effectively? Because it's a chronic, long-standing and persistent thing. And the moment something occurs twice or 3 or 4 times, then you've got the diagnosis straight away. That's just the persistent uveitis. I don't want to call it recurrent myself. So I don't believe it goes away. I believe it sits there waiting and waiting and waiting and waiting for it to come back and back and back again, time and again. And the moment it comes back, you know, we panic and go back a little bit. You know, you give them non-steroidals, you give them some corticosteroids, and they get better. That's probably treatment helps. You know, if you treat it as a immune-mediated uveitis and it gets better, then, maybe that's a diagnosis, and you can say, well, that's probably what's there, Yeah.
Thank you, Derek. That's great. Next question: what is significant about plasma infiltrate? Does it narrow down diagnosis, and does the identification of plasma alter treatment?
Yeah, I mean, if you've got plasma in the cornea of some description, you have to ask how it's getting there, because the cornea should be desiccated, should be completely dry. There should be no plasma. And usually, if you see plasma and the brown or slightly green appearance, usually that means that there's a few cells in it as well. But the brown and yellow makes it get edematous, and so you get that sort of corneal dropsy appearance where the cornea loses shape. It's rather like everything flows down, just goes from up down, and it gets to the bottom and sits there. So you get the shape variation, and then you look at the front and you see that it's got a lot of thickening. You can put a slit lamp on it. You can actually see the cornea is very thick. I mean, normally it should be 0.8 or 0.9 millimeters, something like that, whereas sometimes 2 or 3 millimeters thick. And you got that plasma. So you have to ask how that's got there. Well, plasma doesn't come there from the aqueous. It comes there from the margins. It comes from the edge. It comes from the ciliary body, and it probably comes from blood vessels. So look and see if there's blood vessels inside. So if they're blood vessels, then they're leaking. They're leaking, and the plasma is getting into there, and then you land up with that browny color, which is characteristic of the immune-mediated uveitis. I beg your pardon, immune-mediated stromal or interstitial keratopathy. So these are changes which occur within the stroma itself. So it's not the surface one, and it's not the deep one, but it's the middle one. And so it's a stromal keratopathy. So that's where, and of course that hasn't got any structure. So plasma accumulating in there just fills the gaps. Of course, it goes blue eventually, but plasma remains. It doesn't have quite the same tendency to produce edema in the cornea. So it doesn't go very blue, it just goes slightly blue, but it goes mostly brown or yellow. Yeah.
Grand, thank you, Derek. Just to come back to the uveitis one, I just had an extra question about uveitis to sort of follow on. Somebody's asking, why is the pressure low in acute uveitis?
Right, the pressure drops because the inflammatory change is within the ciliary body. Now the aqueous is produced from the ciliary body and floats down and across, and then drains back through the little sinusoids, which are at the base of the ciliary body on the other side of the pupil. So they're going out from underneath the iris and floating around, and then going back out through the edges where the insertion of the drainage angle is. Now in horses, the drainage angle is a very big feature. There's big spaces that it goes through. It doesn't go through the little canals of Schlemm, which for some reason or other sticks in my mind from my days in university doing small animal ophthalmology, all those kind of things. That name just sticks in my mind. But the horse doesn't, I presume it has them, but it doesn't use them very much because it has a much wider drainage angle. So the drainage angle stays open. But when you damage the udder of a cow with mastitis, it doesn't produce more milk, it produces less. And the milk is not normal. So now the uveal tract does exactly the same thing. So when you get uveitis or cyclitis or ciliary body inflammatory changes, you're going to have a reduction in the amount of aqueous that's produced, dramatically less. And of course, it's going to be abnormal. So that means the pressure is immediately going to drop. And as soon as that happens, then of course now we've got plasma, we've got cells, we get the aqueous flare, we get all those other things which are associated with uveitis. So the pressure will always drop in cases of acute uveitis, in every case. If you start getting high intraocular pressure, it means that the horse has glaucoma. Glaucoma is not the high pressure. Glaucoma is the condition which produces the high pressure. And that's because now the drainage angle is collapsed, but the aqueous continues to be formed. So if you're blocking the plug of your bath, if you will, and the pressure is going to get bigger and bigger until it starts forcing the aqueous into the cornea against the gradient of the endothelial pump. So and then gradually it pushes it into there. It has to, because the pressure can be 75 millimeters of mercury or more. And that's an enormous pressure. Now, if you can open the drainage angle a little, then it'll float out, and that's fine. And that's mostly what most surgical methods do. They try to reduce the pressure and try to pull it down a little bit, because the aqueous is still being produced, but it can't go anywhere. And so that will go on producing it, because the drainage, the plugs are blocked by the inflammatory response or by collapse, and usually by both, actually, in some cases. And then the pressure starts to rise. And now there's a different problem altogether, of course, because a high pressure inside the eye damages everything. It damages the retina, it damages the cornea, it damages the iris, it damages everything. And that's why glaucoma is such a critical issue. And of course, they go blind. And then that's that. The pupil is usually widely dilated, by the way. Yeah.
So thank you for that answer, Derek. I'm acutely aware at this point that we're obviously well into everyone's evenings now. We've had an unprecedented number of questions. I still we're probably something like only 1/3 of the way through them. So
okay.
Derek, I'll be guided by you. Do you want to continue answering?
No, we can. I mean, if everybody wants to stay on and listen to a few more, that's fine. I mean, I learn a lot from doing this, because people ask questions and you think, oh God, why are they asking that? And then suddenly you realize, well, because nobody has that answer. Because that if someone asks a question, if you ask a question, somebody else wanted to ask that same question. So it's a mutual educational experience, and I don't have a problem. You carry on, don't worry about it.
That's fine. We'll keep going then.
Yeah.
Fantastic. Okay, so are some kind of bubbles behind the pupil a pathology? They looked really stable in the eye when seen with the ophthalmoscope. I presume that was in reference to one of your cases in there.
Yeah, I think I suppose what you're meaning is, are the iris cysts. Now, iris cysts look like bubbles that hang usually on the back of the iris, and then they hang over, if they're on the lower lid, they hang over the margin of the pupil. And so when the pupil goes up, they go up, and when the pupil widens, they drop down. Sometimes they can touch the cornea. So if they touch the cornea, then of course that's going to impair the corneal endothelium, because the corneal endothelium has a pump in it which keeps the cornea very strongly desiccated. I've got a statement that I can't remember whether it was John who told me, but I don't know quite how true it is, but it's a great statement that there's less water in the cornea than there is in the atmosphere of the Atacama Desert, which is the driest place on Earth. And that's how the cornea remains clear. The cornea has to remain clear because it's desiccated, and all the collagen fibers all just lie exactly next door to each other in a set pattern, and that keeps it clear. So and that only maintained against the pressure of the aqueous, which is 19 to 24 millimeters of mercury, more or less the same as central venous pressure. The pressure is being pushed in to put water into the cornea. That pump is working all the time. It's very energetic and requires good nutrition. And that's why it needs aqueous. When we say this is aqueous, we don't mean it's water. Actually, you should view this as being Jersey milk for the corneal endothelium. It's nourishing, it's full of all the good things of life that are going to keep that corneal endothelium functional. So if you get an iris cyst, which impacts, or a tumor, melanoma within the iris that impacts the cornea, immediately the area outside that will become edematous. And furthermore, you'll find that the blood supply over the cornea will try to protect that. So you'll get superficial neovascularization, and it will bring pigment with it. And so you'll have pigment, you get a pigmented keratopathy, where the pigment runs over the top of this. So now you've got black, you've got red from the blood vessel, and you've got edema from the cornea, and then you've got fibrosis underneath. So you've got red, white, black, and whatever other color I mentioned there. So you can see that this is, so these bubbles which occur can be very big. They can be cystic granular iridica, or they can be cysts in their own right. And there's a lot of debate as to whether they're the cause of head shaking and stuff like this. And so there are people who've got remote fire lasers, that they can lock onto it and then fire the laser and burst the little cyst. Actually, in the old days, before all this sophisticated stuff came out, we just used to anesthetize the horse and then just put a little needle through the cornea with a little Z entry so that it doesn't leak afterwards, and then impact that and suck out the contents, and they never came back after that. I can't remember one that ever came back. And but sometimes they nowadays we do it by laser in the standing horse. I mean, it's a relatively easy thing. I think Rob Lowe's got one. I think there's several people have got those. I think Fernando's got one at Liverpool. I don't know. Maybe there's several people who've got them, and they can blast the things away. And then of course, if you get rid of the cyst, the bubbles, okay, get rid of them, and then the head shaking goes away, well, then that's fine. Then you've solved the problem. But my experience is that they've probably been there for a long time. They hardly ever vary. Just sometimes they impact the cornea and cause a pathology. Remember that if you damage the cornea, you may even get an ulcer on the outside if it happens very quickly. Yeah.
Sure. Okay. Next question. What is the method of treatment of inflammation of corneal endothelium with that characteristic corneal edema?
Right.
Yeah.
No, it's a very good question. The difficulty is, of course, that you have to recognize it as an immune-mediated endotheliitis. So we call it an endotheliitis, or I prefer to call it an endotheliopathy, and it tends to be immune-mediated. So it can arise out of two different kinds of circumstance. The first kind is when there's a lot of proteinaceous material in the aqueous from uveitis, and then what happens is that the normal circulation of the aqueous means that it cools down and drops down, and then as it warms up against the iris, it starts to warm up, and then it goes up the front of the as it sweeps up behind the cornea, and as it does this, it picks up the protein pieces, if you like, protein molecules, and sticks them on the endothelium. So it protects the endothelium from its aqueous, and therefore it becomes blocked, and then you get the pattern of edema, which goes according to the vortex. That's, in my view, probably one of the commonest causes of it. And when we see that, we know that there's going to be a problem, because the pattern really is very characteristic. And I think Dennis Brooks taught me many years ago that when you see this, be very careful, because although you can manage this thing with, methylprednisolone acetate, Pred 40, or some form of topical dexamethasone or betamethasone, systemic prednisolone, systemic non-steroidals, or even methotrexate, all these kind of things that you can use to try to reduce the intraocular inflammation, you still land up losing the eye in the end. So I think Dennis would agree probably with me that that's a common outcome for that kind of pattern, and that therefore, when you see it, you have to say, what's the prognosis? Remember, right at the beginning of the talk, we said something about establishing a prognosis for the owner. The short-term prognosis probably quite good if you can get rid of the inflammatory response. The long-term implication from that is that the pathology is probably not going to go away, and it boils down to the same old thing, this business of long-standing inflammatory change within the uveal tract of the horse, more particularly the anterior component of that, the cyclitis, the iritis, which are associated with the immune-mediated persistent. As I said, I prefer the word persistent uveitis, because if you say persistent, then people don't expect it to go away. And if owners know that, then they're a little bit better informed, and they seem to take that much better. We say, well, this is a persistent problem, you have to manage it forever. We say, okay, that's fine, we manage that. And you say there are periods when it's going to go away, but it's not going to actually go away. It's going to come back and go and come back and go, but it'll be there all the time. So you have to manage it all the time. And then the owners don't expect it to go away, because I just not sure that it does go away. And that's why you get these patterns of edema, mostly as a consequence of the protein. Sometimes it's within the endothelium itself, where there is actual inflammation in the endothelium, and it's hard to understand why that occurs. It's very hard to understand because there's no vascularity there, and it really has to have something. It has to have some blood vessels going to it, and it doesn't. You don't get blood vessels going to it. So yeah.
Okay, so now following on from that, then this next question. How do you distinguish herpetic keratitis from immune-mediated keratitis?
Right. Well, herpetic keratitis is a very interesting condition, and there's a lot of debate about exactly what it is. And of course, we know that if you are going to take swabs and so on from it, you can do PCR for EHV5. And I think most people think that it's not one of the more conventional herpes viruses, but it causes an acute pain. Cats get it as well, and they get very, very painful eye, and humans get it as well, extremely painful eye with people as well when you get herpes keratitis or keratopathy, whatever you want to call it. And they're very focal, very tiny focal areas. The blood vessels race into it. The blood vessels really race in toward trying to resolve it, but you land up with these little punctate areas, and when you stain them, you can look with a strong magnifier. You can use your telephone for that as well, by the way. You can actually see tiny little areas of ulceration. So each little area is an ulcerated site, and it's rather like having a cold sore on your lip. When people get cold sores, I don't know how many people get those anymore, but if you get a cold sore coming, it's excruciating painful to start with. And then you put the Zovirax on it, and that helps it a lot. Of course, that does the same for the cornea. So when you've got more than one little spot on it, then you can say that's going to be painful. But of course, very quickly they heal. The blood supply gets in, they heal, or they just heal anyway, and then you land up with little punctate scars. It does tend to resolve, and you can use an antiviral drug, and that makes the diagnosis, of course. But if you have blood vessels going into it and it's not painful, because most of the immune-mediated keratopathies are not painful, not badly painful, uncomfortable in some cases, but sometimes completely non-painful. They just have the pathology. I showed you that picture, that brown one. It was a thoroughbred horse, and he had this for weeks before anyone said, "What the hell's going on here?" And that had been going because there was no indication of anything. It was just very obvious pathology. And was it significant? Absolutely. Was it significant to the horse? Well, maybe he couldn't see very much out of this the lower half of his eye, but he didn't seem bothered at all. But we did manage to get rid of it. I mean, it's a difficult condition to deal with. You have to peel it all off. Sometimes you can use a little alga brush and just sweep off all the corneal epithelium and get down to something and let it heal properly again. But if you do that with a herpes, it's not good, because you spread the herpes everywhere and you get bigger ulcer after all. So be careful. These kind of things are very dangerous. And if you're in doubt, just get your videos taken, use your smartphone, do some phonioscopy, zoom it off to, I know Andy's out of the equation at the moment, though I very much regret that, because he was an amazing guy, Andy Matthews. But, Rob, Tim Knott, these kind of people dotted around and about the countryside, and they're very good. Fernando at Liverpool, very competent ophthalmologists who can give you chapter and verse about whatever's going on, even just from your phone. And it's a wonderful resource. Just be careful, practice taking it, practice doing it. Yeah.
Well, we have a great question that follows on from that, because one of the audience has said, and sadly the person who asked has actually now left, so but we'll follow up with the answer. What's the best camera app to use for videoing or photographing the retina? Yeah. And she specifically said retina, but
yeah, okay. So the one that I use that's on my phone, I'll just get it here. It's called Camera Plus. Okay, and there are several different cameras that I've got on here that give us different things. So there's something called Camera Plus, which is Camera Plus, or you can get the one that's got a camera and then a plus sign next door to it. We used to use Camera Awesome. That was amazing because you could dim down the light, you could leave the light on, and that's the secret. You have to be able to keep the light on your camera on all the time. So looking at this, if I go onto this and go to Pro Camera, the other one is called Pro Camera, And if I showed you this, then you've got the light facility, the camera and the bulbs that go with it. Okay, so you can turn those on or off for the video. So when you're going to a video, you can turn on the light on the camera. So there's a little icon at the top. If anyone's interested in that, I've got a little thing that I can send out that helps you with this. It's a very good way of doing it. So because you've got to have the camera, the light, but if you haven't got a rheostat on the light, you need to stick something over the light on your camera. So because it's the delay, you see, when you're trying to use a flash, and more particularly when you're videoing. So let me see if I can just do that on the camera plus, because if I can do that, I'm just going to switch on the camera plus now on my phone. And now I'm just going to go to the light source and I'm going to put the bulb on. Now I've got that, you see? So I don't know if you can see that, but I'm looking at the eye now through this, you see? And I've got the light. Now I've dimmed the light down by sticking a little bit of elastoplast over the surface. That stays like that. I don't use it as a torch ever, but this way you can then take some photographs with the thing. You can run a video, you can run anything, but you mustn't have this too bright because the pupil then constricts. So dim this down as much as you can, but it's very important that the light stays on when you are taking your video. Very important. So test your camera apps. So camera awesome was great. Camera plus, camera pro camera, or camera plus, or camera plus sign. You know, plus sign like that. Yeah. Yeah.
That's brilliant. And for anyone who's listening, we'll disseminate these bits and bobs after the event as well for anyone who is interested.
Yeah.
If you've got time, Derek, there's still a few more to go. If you're okay with that.
Going. Yeah, keep going. Why not?
The next one, I seem to remember hearing you or Dennis talking about at Beaver some years ago. Somebody's asked, can we use commercial amniotic membrane extract on an infected eye?
Oh, you know, the use of amniotic membrane on the eyes is a bit of a controversial topic. On an infected eye, I wouldn't do it in any case, because actually what you're doing is just sealing the infection in, and you can't get access to it. So usually we use it where there's an ulcer, that we've controlled and we want to get protection. So it's a good way of doing that, but the amnion has to be properly prepared. You can't use the Allanto or amnion. You've got to split it. You've got to prepare it properly. There are commercial preparations for it, and remember that you've got to put it the right way up. It's not going to stick there. It's not going to stay there. It's going to act as a protection, and you have to suture it into place very carefully. So be very careful when you're doing this. It's not the greatest thing to do in an infection. I would not use it for that. I think there's a time and a place for it, usually associated with extensive ulcers, and more particularly, for example, when you've removed a massive corneal carcinoma in situ, for example, across the whole surface of the eye, when you want to protect it. It's a good thing for that, because you can suture it limbus to limbus and stick it on there. And provided you've got the allantoic surface of the amnion, that's the inside surface, against the cornea. Don't put it the other way around, because it'll do no good whatsoever. And it'll just peel off. It'll just make an awful mess. And it's a good thing to do. And when I was just leaving Liverpool, I did a little preparation of fetal amnion. So where horses at the slaughterhouse were slaughtered and were found to be pregnant, could take the fetus, and then you could derive the fetal amnion. It's a tiny, very thin membrane. This is beautiful to handle, and of course seemed to work extremely well. The amnion is tough, but also has a very protective capability and a lot of mediators and so on the inside surface of it, not on the outside. There's no point in putting it there, but on the inside. So if you put it round the right way, that's great. The problem is when you take it off your tissue, do you know which side is up? And when you take it off the little applicator, you must keep it the right way up. Otherwise, you've got a 50-50 chance of getting it wrong. And if it's wrong, it'll do absolutely no good and may do harm. So get it right. and there's no way you can label it at all. I think of trying to find ways of staining it red or green or blue or something on one side rather than the other, but it's so thin, you know, in the fetal ones it's very difficult to see that, but you do have to split it, you know, and it's quite easy to split when you get the technique. You can just split it out, and it works quite well. Yeah.
Fantastic, thank you. Next one, a bit different. What is your view on the role of vitamin A in regenerating the blood supply in corneal ulceration cases?
Yeah, I mean, there's a lot of all this kind of thing going on, and a lot of people who have very strong feelings about whatever they do, and there are a lot of new methods for dealing with corneal ulceration and trying to get them to heal, and this is one of the suggested mechanisms. I personally don't have very much experience of it, but I can understand why it's done. I just don't quite understand what the pathology is that encourages it. So I think if you recognize that, you know, nature's been healing corneal ulcers for billions of years in billions of animals over the years, and has done quite well with it, really. So I think if you can address the issues of the ulcer, in other words, the reason why it's there in the first place, and what secondary infections you have to deal with in the second place. So you need to know that, because you need to focus your attention on it. So if it's a bacterium, what kind of bacterium? Is it a gram-negative, gram-positive bacterium? Is it producing collagenase? If not, you know, that's good. If it is, then you have to counteract that. Or whether it's a fungus. Now, funguses are hideous, okay, because they burrow down and they sit just above the decimase membrane, just right on the basement membrane of the endothelium. So that's decimase membrane. That's where they go, and they burrow down. So when you take a swab from the outside, you don't get a great swab. You know, you may get a little bit if you're lucky. And remember, don't use a cotton swab, because it's very difficult when you've got a lot of cotton fibers all staining as well to see what's fungus and what's not. So use a cytobrush. They're very cheap and very easy, and you can get these. They're disposable. You just have a little cytobrush, you just put it on there, but you do need to scrape. You know, for funguses, you need to scrape to get deep down and make sure that you get it. And a lot of people are very worried about doing that. You know, so it is difficult. Whether you want to give them, you know, some magic that's going to solve all the problems is another matter. I personally believe that we should address the issue so that we allow nature to do what it does best. That is to heal a wound. And nature heals beautifully if you give it the chance. So if you support it rather than try to interfere with it. I suppose it's rather like, you know, the healing process best viewed as an orchestra playing Mozart, you know, and it's playing beautiful Mozart. And if you bring Mick Jagger and the Rolling Stones in other words, infection, and they start playing, you know, a Can't Get No Satisfaction or Jumping Jack Flash or something in the middle of the orchestra, it's no longer good. So what you have to do is you have to call in the police now to come and get rid of them. So they disrupt things, they stand on a few violins, they crash a few things, but they remove Mick Jagger and the Rolling Stones. And so the orchestra can start up again. It's never quite the same because some of the instruments have been trashed, but they do their manful best. And then when the orchestra is completely reconstituted, the thing is healed. I suppose if you're trying to bring in 10,000 new violins, you know, does that make the orchestra play better? No. Does it distort the music? Yes. Does it change? Does it make it the same music? No, it doesn't. So we've got to be very careful how we manipulate healing processes, whether that's a wound on the horse or whether it's a corneal ulcer or it's a tendon injury or whatever you like. You know, just be careful that you don't do harm by doing too much good, if you get my drift. No, so a little bit of retinoid, a little bit of vitamin A is good. It's a, you know, retinoid form, and that may be something to work on. But there's lots of other new methods which are being used with some good success in some cases. But the reality is it shouldn't be used as an excuse not to get the corneal ulcer right in a healing state. And that's the key, I think, to trying to get it corrected. Yeah.
Sure. So sticking on treatments a bit more topically now, another commentator has put that when using gentamicin ointment, I see much more corneal edema compared to when using other ointment. No specifics of other ointments. Is that in line with your experience?
No, not particularly, but to be honest, I've not really thought about that. It's a very interesting observation. I don't know quite why that should happen. Usually, if you use something that kills the bacteria, and if the bacteria are dying inside the cornea or inside the margins of an ulcer, you can imagine that it would release mediators that may cause more cell damage, I suppose, though there are not a lot of cells in the stroma, of course, but you're trying to encourage the epithelium to close over the surface of it. So it may attract more inflammatory mediators and more edema, I suppose, because blue and edema means blue is blue, of course. And so if you're getting more corneal edema as a consequence of the gentamicin ointment, I would look at the formulation of it. I don't know quite what the pH is of that. I don't know what that should be. I mean, pH is an important issue for healing because it should be slightly acidic, and acidic things, are more conducive to bactericidal effects because bacteria don't like living in an acid environment. So, but I don't quite know what the pH of those gentamicin ointments are. Yeah, personally, if that's happening to you, I'd ask the manufacturers to just give you some more information about it. Find out what the pH is. I've no idea. I mean, I've always used gentamicin drops, and if necessary, chloramphenicol or aureomycin or tetracycline ointment. But I know that there are gentamicin ointments out there. I think they're commercially licensed and everything. So that should be listed as a side effect if that's what there is. And I can't remember looking at the data sheet and reading it. Maybe you should read the data sheet and just see if they mention anything about corneal edema, whether anyone else has noticed it. Be interesting to hear from other people if they've also seen that. But I can't recall seeing that, I have to say. Just hard to understand.
Sure. Well, it would be interesting to, if anybody else is listening here who has had a similar experience, to I think to hear from them. A couple I'll sort of run together, Derek. Firstly, have you had any success with intravitreal gentamicin injections for the treatment of persistent uveitis? And would you consider cyclosporin implants beneficial in this case? And I think this case is labelled as the endothelial inflammation case.
Yeah. Sorry, I beg your pardon. Yeah, I mean, cyclosporin is a good way of dealing with supposedly a good way, at least, of dealing with the immune-mediated keratopathies, because it's a T-cell modifier, of course, and that's really why I've taken to treating them with methotrexate, which does the same thing in a very mild but long-term manner, and that seems to work very well indeed. And it's a very safe drug. It's an anti-metabolite rather than anything else, and so it's quite a good drug to use for that. And it is a very strong immunosuppressant. Now, as far as cyclosporin implants are concerned, I think the technology behind them has improved dramatically. Brian Gilger's really driven that from North Carolina, and he's a great guy, and he's really has driven this hard. And he was the guy who first developed the little round ones. Now they're stick ones, and they're much easier to use, and it's much easier to place them correctly. But for uveitis, my experience was that it was okay and kept the horses free, or at least limited the severity of the progression of the disease for an extended length of time. But ultimately, they didn't last forever. And then you find you had to go again, and then it didn't work quite as well as the second time as they did on the first time. But maybe that's changed now. I don't know what the concentration of the new ones is, because I don't have case exposure anymore. But I think that's certainly a medication that is worth using for sure. The problem is getting the bioavailability if you're going to try and get it into the eye. So my impression that is it doesn't penetrate the eye very well at all, and so you do need to apply it frequently, and whether it's just an additional help is okay. But for the superficial things, superficial keratopathies works reasonably well. You can use the corticosteroids alongside, of course, because there's no ulcers. In any case, it can be indicated for that. So as far as the first part of the question is concerned, the use of gentamicin in the back of the eye, that's useful in some cases, usually combined with triamcinolone. So you put, I think it's 4 milligrams of gentamicin in a non-preservative gentamicin, and you put that in and you combine it with a little triamcinolone, 1 milligram of triamcinolone. The problem with this combination is if you overdo it, you'll kill the eye. So if you want to kill the eye, then you put in a big dose of gentamicin, because that's going to kill the eye stone dead. So what you've got to try to do is to remember that, leptospira related uveitis, not a very prominent feature of United Kingdom uveitis. On Europe, it's very common. And they even culture live bacteria out of the vitreous when they do a vitrectomy, because of course vitrectomy is a standard procedure for a lot of warm bloods that get uveitis in Germany and Holland and Austria and places in Switzerland, and they all pool into Gerhardt, Helmut Gerhardt in Munich, and they go in there and he does them regularly and he just whistles them through as quick as a flash. He's very good at it, and he's had exceptional results. But of course they culture from the vitreous that they aspirate, they remove, and they find leptospira in it. So they always use antibiotics in it, as far as I understand it as well. And once they've removed the bacteria and removed all the gubbins and the vitreous inside, then these horses often go on and remain normal for a long time. Whether they are always normal, I don't know, but certainly there's no evidence that there's any long-term complication from it. But you need to be experienced at doing it, not a thing that you could just learn overnight. I mean, I did some, but it was very difficult because mostly the ones I was doing, you couldn't see through the lens as well. So you had to have a second camera, which had to put in through a second port into the vitreous and through the pars plana, and that was very difficult because if you touch the lens with either of the instruments, that's the end of the lens. Just cataracts immediately, and makes a disaster area. So it is a difficult thing conceptually, but I think the intracameral injection of gentamicin and triamcinolone can be useful in those cases which are severe, for which there's no surgical option, and where perhaps the cyclosporin implant is impractical as well. So you can do that. It's not a difficult procedure for sure. You just put them in 1 ml syringes, one after the other, and you just pop the needle through. You lift the horse's head up, you look down, keep it well sedated. If you want to block the orbit as well, that's fine. Block the upper eyelid, and then just pop it straight through into the vitreous and inject it. It's just a little bit, it makes me feel slightly queasy, actually, to be honest. And sometimes you hit a blood vessel, in which case it just fills with blood, and that's not great. It's not the greatest outcome. Yeah.
That's absolutely brilliant. I think I've covered everything there, Derek. If there's anything outstanding, then my apologies to the questioners in question. I will follow up afterwards and pass on anything that has not made it through this evening. I think once again, on behalf of our very large audience here this evening, thank you so much for your time. It's obviously a large chunk out of your evening, and we are extremely grateful to you for your efforts on that.
It's a real pleasure. It's been a real pleasure, and thanks to everyone for listening. I'm not a card-carrying ophthalmologist, so I'm a practitioner. That's what I am, and I have been most places where most people have been, on a dark stable somewhere with a bad eye, and you feel a bit lonely there, I think. So I hope this has helped anyway. Yeah,
I have no doubt it will have done, and I also would like to take the opportunity to just once again plug your Vets with Horsepower efforts, which am I right in saying 29th of April, Derek? Is that correct?
29th of April, starting at 8 a.m. London time, and you can register online. We're asking for donations of £10 for the. If you want to pay more, if you want to give more, if your practice wants to pay a practice sponsorship of £350, we'd be very grateful to receive it. But anyone who wants to pay more can do so, because it's all going to charity. Every single penny of this goes to charity, and we got 23 amazing speakers giving 32 lectures over 25 hours continuously. You don't need to stay up all night. You can get the recorded thing. Once you've got your key, you've got 4 weeks to look at them. That's, you know, 1 lecture a day for 4 weeks. Well, you know, that's an extraordinary benefit, and you get certification of it. It's qualifying for 25 hours in most countries. We can get 8 hours in Germany, I believe, for technical reasons, for some reason. But for most countries, you can put down 28 hours, because that's what it is. It's 28 single hours of lectures continuously. It's a world record. And how many times can you say, I took part in a world record, I was a player in the team? Well, join us. We need 5,000 delegates if we can, more if possible, and we need as many countries as possible in order to break those records as well for veterinary audiences. So, you know, I'd be hellish grateful if everyone would support it, even if you're not that interested in the lectures and stuff. There's something there for you, and it's the charities are undeniable, and they desperately need help this time. So we are all giving our time. We hope everybody just have a fun in a dark world. You know, it's just a little candle in the light. Yeah.
That's fantastic, and we're all raring to go. I hope everybody has enjoyed the evening. Please note that we are producing more webinars as time goes by, and we have also available a increasingly sizable these days library, if you like, of past webinars. We're also always super keen to hear any ideas people have or requests people have for subjects for future webinars. So again, if there's anybody listening who thinks I'd really like to hear so and so talk about such and such, then please don't hesitate to get in touch. You can do so via our website, the usual, all the usual sort of social media channels as well, and that's where you can undoubtedly find our existing historical content. I think that is probably a reasonable time and place to wrap up. So I thank you, Derek. I thank everybody who's listened for their patience. I hope you've all enjoyed, and I look forward to seeing you all at 8 o'clock in the morning on April 29th.
Great stuff. Thank you.
Take care. Bye-bye, everyone.